Hello, everybody. Welcome back to the Incubator Podcast. We are live at the CHNC, and we are joined by Daphna. How are you first?
I'm doing great.
Good. We're joined by Sofia Perazzo and Jenny Rumpel. Guys, welcome to the show.
Thank you. Thank you for having us.
Can you tell us, so you're here to talk to us a little bit about the renal focus group.
Mm-hmm.
And
Right.
so my first question to you guys is, what are the areas that you are targeting either in the past few months, in the coming few months, that you feel are very high yield for the neonatology field?
Well, we have, as the kidney focus group started in 2021, 2020, and we wanted to see how much we can leverage all the data that the CHND has. And we realized that we have a lot of diagnoses, so maybe focusing on all those babies that have CACUT diagnosis is really something that we are looking into very hard, and we've been looking into. And we also were very interested in, how the AKI field is advancing.
Absolutely.
Trying to bring this to all neonatologists to have it more present, and also we like really a lot of, into technology, and so we did a survey on RT practices and NIRS practices in since checking how the kidney is doing. So,
What did you find?
So RT practices are really varies along among centers. So there are centers that are doing really a lot, while other centers, they are still lacking a lot of the technology. So we did a workshop, as you know, guys, trying to, level the playing field a little bit in knowledge across the two fields. The NIRS happens a little bit the same. There are different equipments out there that people use, so it depends on which equipments each center uses. And it's less standardized, so we would like to, help standardizing all kind of I would say the markers that we use to help kind of, bridge the gap in knowledge across centers.
We've talked about RRT for a few minutes now, and we haven't even said what RRT stands for, so I just want to make sure that we talk about it. So, renal replacement therapy. Can you tell us a little bit about what RRT entails? Is it dialysis?
Baby dialysis. So it can be either peritoneal or hemodialysis. And we have newer neonatal-focused dialysis devices now, like Carpe Diem, which was just approved in the U.S. by the FDA in 2022. And then Aquadex, which can be modified to perform dialysis, is an adult heart failure device that's not really approved in neonates, but is oftentimes used.
And so I feel like this is really changing the field right now. And can you tell us a little bit how that's happening? Because some people may be listening and may say, oh my God, dialysis. This dialysis is still dialysis, but how is that reducing the friction to actually roll these interventions out into NICUs that may not have in the past been big dialysis centers?
Well, I mean, it's nice that it's FDA approved.
For sure.
So I think you can get your hospital to buy into that,
right,
and purchase the devices. So since we're not doing something off-label. But the biggest thing is that there's a lot smaller extracorporeal volume needed with Aquadex and Carpe Diem. So it's just safer, and the babies tolerate it more, that you don't have the hypotension going on. So I think it's going to really take off, and we'll be able to dialyze smaller and smaller babies. And then as we get more comfortable, we'll be able to be more aggressive with babies that we usually offer comfort care, like, when the babies that are born with bilateral renal
agenesis.
Yes.
And I think that also, working very closely with nephrologists is really something that it will help both professionals kind of collaborate more and be less afraid of treating these babies more aggressively, if you would say, like you offer dialysis when before it was not offered. I think that that's something really, collaboration here, it's a key point.
Well, I love that perspective, and it's such a highlight of what the CHNC does, right?
Exactly.
Collaborative across disciplines. But I mean, RRT is a small part of our population, but we see AKI every day in the NICU, right? So that collaboration, I think, with the nephrologist or just a better understanding of the kidney is really, I think that's a change just we've seen in the last handful of years, a focus for neonatologists.
I think that all the research that everybody is doing on AKI and in neonates, it's really helping bring awareness. That is it's actually what we need here, because we used to say, creatinine rise, that's it. Or,
it goes up, it goes down.
It goes up and go down.
Babies die with kidney injury.
It's
not because of kidney injury.
So I think that we can do something, right? We know that it's there.
And that's the history of medicine, basically, where once the tools become available to measure something, we can actually start studying it, start understanding it better, and start improving outcomes. So I think it should not be lost on everybody that we are at an inflection point when it comes to what we can offer our patients from a renal standpoint. And I think that the next 50 years of neonatology are going to see a huge presence from the nephrology teams, both intra-hospitally, where we have babies being cared for from a kidney standpoint in the NICU, but also with long-term follow-up that we're learning more and more about, has just tremendous needs for follow-up of these small babies or babies with congenital renal disease.
Absolutely.
But I think to your point, actually, you mentioned NIRS, so we're pretty familiar with NIRS, near infrared spectroscopy.
Careful, we're pretty familiar.
All right, well, we trained with NIRS, so
we play with NIRS.
I recognize that some people hadn't even are not even using it. They're not familiar with it. They don't have it in their unit. They didn't train with it like we had the opportunity to do. We at least have a few units. We use NIRS. But I think NIRS, from a renal's perspective, is still pretty emerging data. So tell us a little bit about that.
So we published a survey on NIRS practices for renal NIRS across the CHNC. So we published that about a year ago. And again, practices varied. Some centers don't even.
And that's in Journal of Perinatology, right? If anybody wants to take a look, the March edition.
Yes. Matt Hare was first author. And then currently we're writing a review that should be submitted for publication soon, really looking at the available literature on renal NIRS and giving some guidelines for norms as far as, with the data that we have currently.
Yeah, which is something everybody's been asking for, and more normative values are...
exactly. That is what I think that from our survey, what we learn is that, everybody not only use different equipment, which is fine, but then what is your baseline? I mean, how do you use your data? Do you usually use your data in rounds, right? So what's the point of putting the baby on NIRS and then nobody's looking at what's going on?
That's right.
Right? So, and there's a huge practice when you use NIRS for the brain, but not so much for the kidneys. So we want to, let's see how much this data is telling us and how we can use it in our advantage, the patient's advantage.
I love that, because it means that collaboration is going to be key. You mentioned the idea that we have a lot more familiarity or frequent use of NIRS with the brain, and that's because the cardiologists have been already using it, and I think it's the collaboration with the cardiology team sharing data that has allowed us to roll this out in the NICU more readily. Now it's the time to work on kidney NIRS with a nephrologist and make that collaboration work.
Hopefully we will make it work.
Of course. Well, thank you both for dropping by, and congratulations again on this impressive work.
Thank you.
Wish you a good rest of your conference.
Thank you.
Thank you.